Hello and welcome everyone. Today's presentation is on hypocalcemia in critically ill patients. Now, critically ill often have low extracellular calcium levels and potentially high intracellular concentrations. Now, serum hypocalcemia is linked to worse outcome in these kind of patients. Now, physicians sometimes administer parenteral calcium to correct hypocalcemia in critically ill patients, but this is often done without any clear or evidence-based threshold. Now, there is an ongoing debate whether supplementing calcium in critically ill is beneficial or not. So, before we do that, let's see what is the calcium homeostasis. Now, the role of calcium is crucial for various physiological functions like cell to cell signaling, membrane potential, neurotransmission, and blood coagulation. Now, almost all the calcium in the human body is stored in bones, with only 1% residing in the extracellular component. Now, intracellular calcium is a second messenger which plays a vital role in cell differentiation, contraction, mitosis, and cell death. In healthy conditions, calcium levels in cytoplasm and mitochondrial matrix are significantly lower than in the extracellular environment, regulated by plasma membrane transporters and storage in the non-mitochondrial organelles. Now, external stimuli can temporarily increase the cytoplasmic calcium levels either by the influx from the outside of the cell or release from the internal storages to interact with the intracellular proteins. Now, mitochondria use transient increase in the cytoplasmic calcium to signal energy demands, activate ATP synthesis, regulating the reactive oxygen species production. Now, severe stress like cell damage or inflammation can cause excessive cytosolic calcium, leading to mitochondrial damage, leakage of the mitochondrial components, uncontrolled autophagy, and additional cell damage. Excessive intracellular calcium can lead to cell apoptosis through activation of calpains and caspase proteins. Mitochondrial dysfunction, particularly in the critically ill, can lead to cytosolic calcium overload as it impairs the function of the calcium ATPase pumps, which normally maintain a low cytosolic calcium levels. Now, studies indicate that the intracellular calcium is elevated in various severe illnesses, especially those involving excessive inflammation, as has been observed in the animal models. Now, the levels of extracellular calcium is primarily regulated by parathyroid hormone, vitamin D with some influence from calcitonin. Calcium homeostasis is closely related to phosphate and magnesium balance. Hypomagnesemia and or hyperphosphatemia can decrease serum calcium by reducing the PTH secretion and its activity. In healthy individuals, less than half of the serum calcium is buffered by amino acids like albumin and globulin. A small portion forms complexes and the other half exists as ionized calcium, which is the biologically active form of calcium. Now, the levels of ionized calcium are influenced by the acid-base changes. Acidic pH increases the ionized calcium while alkalosis decreases it. Therefore, the ionized calcium levels can be altered by variations in protein, acid-base status, and electrolytes commonly seen in critically ill patients. Now, it is generally advised to measure the ionized calcium directly in ICU instead of using formulas to correct the total calcium due to these alterations. Now, in critically ill patients, systemic inflammation and impaired organ function affect the extracellular calcium homeostasis. Circulating cytokines can increase the calcitonin secretion and decrease the PTH sensitivity. This can lead to decreased calcium reabsorption, reduced activation of vitamin D, impaired phosphate clearance, all contributing to a lower extracellular calcium levels. Now, common in critically ill patients is the gastrointestinal dysfunction. This may lead to impaired absorption of the nutrients, including the calcium and vitamin D. Now, iatrogenic causes are certain medications like diuretics, catecholamines, and infusions like phosphates and citrates, which can contribute to hypocalcemia. Now, due to these various mechanisms, critically ill patients are prone to ionized hypocalcemia, a condition of low levels of ionized calcium in the blood. Now, what is the consequence of this hypocalcemia in critically ill? Now, the prevalence in the ICU patients is ionized hypocalcemia is common among the ICU patients, that is occurring around 55 to 88.5% of them. But classical symptoms like tetany, seizures, prolonged QT, and cardiac dysfunction are rare and obscured by the acute illness. Hypocalcemia is generally defined as ionized calcium less than 1.15 millimoles per liter. Symptoms and severity vary, making it a significant focus of research. Hypocalcemia is linked to markers of disease severity in critically ill patients, including the SOFA score, Apache score, lactate, and albumin levels. Now, the impact of hypotension during CRRT, moderate hypocalcemia can be associated with hypotension during the CRRT, potentially affecting the vascular tone at the left ventricular function. Now, protracted hypocalcemia and sepsis can increase the frequency of critical illness, polyneuropathy, and myopathy in critically ill patients. Regarding the recovery and prognosis, hypocalcemia is often transient, recovering spontaneously in ICU patients during the convalescent period. Persistent is more frequent in non-survivors, indicating a potential marker of refractory illness. Now, as a marker for contributor to the illness, it is unclear whether the hypocalcemia contributes to the apoptosis or is a response to the cell damage and the mitochondrial dysfunction. Now, studies show inconsistent association between hypocalcemia and ICU survival. Some find a link with increased mortality, especially in severe cases, but others find no significant association. Now, current evidence does not support a causal relationship between the lowered calcium levels and poor outcomes in ICU. Hypocalcemia may instead be a marker of the disease severity itself. It is suggested that hypocalcemia might be an adaptive response to the critical illness and the tissue damage rather than the cause of cell damage, but this hypothesis requires further confirmation through other studies. Now, how do we actually manage hypocalcemia in ICU? Now, in the background of this information, the Society of Endocrinology advises treating the underlying cause of hypocalcemia. That is, try to correct the hypomagnesemia, the vitamin D deficiency, the hypoparathyroidism, and providing oral calciums for mild cases and IV calcium gluconate for severe cases. The empirical dosing of IV calcium is to keep the eye calcium levels above 1.125 to prevent severe hypocalcemia. Now, oral may be ineffective for critically ill patients due to impaired intestinal absorption. Now, European trauma guidelines recommend calcium chloride for patients with significant bleeding to maintain the coagulation, but this is based on low quality of evidence. Regarding cardiac arrest, routine calcium administration during cardiac arrest is discouraged, especially in situations like hyperkalemia, severe hypocalcemia, or calcium channel blocker intoxications. In these cases, you may use calcium as a drug for cardiac arrest. Now, there are no recommendations for supplementing critical illness induced hypocalcemia in asymptomatic and mild cases. Now, systematic reviews and studies suggest that parenteral calcium does not significantly impact the outcomes in critically ill patients. Calcium administration is common in ICUs, often attempted to correct the hypocalcemia, although evidence supporting its efficacy is limited. Observational studies indicate that calcium administration might be associated with new onset shock, lower time to shock resolution, increased use of ionotropes in those who normalize calcium levels following supplementations. Now, studies in septic models suggest that parenteral calcium can exacerbate inflammation, cell damage, mitochondrial dysfunction, and worsen the organ dysfunction and survival rates. Pre-admission use of calcium channel blockers is associated with reduced mortality in septic patients, potentially due to the inhibition of the excessive calcium influx into the cells. There's increase in interest in the vitamin D supplementation in critically ill, which might positively affect the critical outcomes, especially in severe deficiency patients. Its effect might be more related to the immune modulating function of the calcium homeostasis and recovery. Now, this is a table summarizing the calcium administration and the outcome parameters in acute critically ill patients. Now, these are the various studies, total 6 in number. Most of them are retrospective and observational. This is the population size, the largest being from China. Most of the cases are from mixed ICUs, some are specific only for septic patients. Now, the prevalence of hypocalcemia, as we have seen, ranges from 55 to 80. Now, calcium administration is done parenterally in most of these scenarios, and the main finding is that calcium administration was not associated with improved outcomes, and in some cases it was associated with worse outcomes. So based on this, currently we should not correct the calcium until and unless the patient is symptomatic because of the calcium. For mild cases, it is not required to correct the hypocalcemia in the ICU. And we need further research to see whether the calcium level decrease is a protective response or the calcium level decrease is a thing which is associated with worse outcomes. Thank you for your patience.